Schwartz from the University of Colorado, and my co-chair is Jonathan Leff from Intermune. Jonathan is the head of research and development at Intermune, and he's filling in for Bill Bradford, who is on his way to the meeting here in Italy, but unfortunately he had a family problem. His son broke his arm, and he had to go back and take care of him. So Bill sends his regrets, but Jonathan is going to fill in and help lead this session. So why don't we get started? Our first speaker is Kevin Brown. The title of his talk is Development and Progression of Pulmonary Fibrosis, Insights from the Clinical Context.
How's that? Okay, good. Okay, I'm Kevin Brown. I'm a lung doctor from Denver, and the thing is off kilter again. So I'm going to talk about the clinical context in lung fibrosis. And while there's been this focus earlier in the conference on this very strict and narrow phenotyping, which makes sense in a number of ways, particularly when you're using mice, I'm going to try to offer an alternative explanation for why we might want to go in another direction. So, is there any way that we can actually fix this? Because this is going to be a problem. All right, so when we think about the big picture of interstitial lung disease where IPF lives, we talk about these classification schemes that involve the clinical context in which that interstitial lung disease occurs and the chest imaging pattern generally on high-resolution CT scan, which is really just a predictive tool to try to guess what the underlying pathology found on surgical lung biopsy would be. So we try to put all those things together, right? So when you drill down and limit your ideas to things about pulmonary fibrosis, you can really talk about a handful of things. So we talk about infection because in the big universal picture, the thing that probably causes the most fibrosis in the world is mycobacterial disease. So TB causes fibrosis in the lung, though we spend very little time thinking about it. And if you're Seamus Donnelly, maybe you think that viruses actually are responsible for a fair bit of lung fibrosis again. On the other extreme, we think about this idea of genetic conditions or recognized genetic conditions, and David Schwartz has done a lot of this work thinking about familial forms of pulmonary fibrosis now that we have identifiable defects that are associated with the development of fibrosis, and there are things, more unique things like Hermansky-Pudlak syndrome, also associated with that. But a lot of the things that we spend our time thinking about are those that are associated with systemic disorders. And so sarcoidosis, probably just based on its prevalence, is associated with actually a lot of fibrosis. and then the collagen vascular connective tissue diseases, which have this unique relationship to lung fibrosis that we'll come back to. And then there's this giant thing that for those of us who see patients, it's about the exposures. And so you spend a lot of time trying to tease through these potential exposures and thinking about their association with the development of fibrosis. So once you've excluded those things, active infection, underlying familial forms of fibrosis or interstitial lung disease, systemic disorders, and those things that one might be exposed to that are associated with the development of the disease, you end up with these idiopathic diseases, right? And so that's what we consider the idiopathic interstitial pneumonias, with idiopathic pulmonary fibrosis being responsible for probably 2/3 of those. And we can argue about some of these being associated with real fibrosis, but this is the list that we come up with. So we spend a lot of time talking about IPF for all the right reasons, but when you think about how we define it these days, and so this is from the 2010 ATS, ERS, JRS, ALAC criteria. So the first thing we think about is how to exclude these other possibilities that might explain why one has lung fibrosis, and then the presence of this UIP lesion, either on chest imaging or in some combination with surgical lung biopsy if the HRCT pattern is not definitive enough to predict with great reliability what one might see if you did a surgical lung biopsy. So that number one there is there because we know, though some of us might argue about this, that if you had a UIP pattern seen on chest imaging or a UIP pattern seen on surgical lung biopsy, that's not the answer. So the pathologist can't give you the answer. It's not lung cancer. They have a pattern that they provide you. You put it into the clinical context, recognizing that all those things that we just talked about could easily confuse one if you had simply a UIP pathologic pattern. All right, so we're gonna do a 20th century audience response system, and so I'm gonna put up some sort of questions, and you're just gonna raise your hand if you think these are true or not true. And we're actually going to go into an alternative universe, and that alternative universe is as follows. Everything is exactly the same, except that everybody in this room takes care of patients, and there is no resource limitation. So if you're a company, you can develop a drug for nothing and make as much money as you want. If you're a doctor, you can prescribe and not worry about how much it costs, and if you're a patient, you don't need to worry about whether you can get the drug or not. And so we're going to have a study that is without question safe and efficacious. So there's no disease progression, you live longer, you feel better, you do more, and there's no harm associated with it. And these are the inclusion criteria that were associated with this study. So you had IPF, age, physiologic impairment, and your gas exchange, and this is what was excluded. So we got rid of everything that wasn't UIP, and you couldn't be on a lung transplant. So this is really actually generic inclusion and exclusion criteria for those of us who've been involved in these sort of things. All right? All right, so safe and efficacious. We don't have to worry about resources. Everybody in here takes care of patients. So a patient with this syndrome comes in to see you. Who treats this patient with this drug? I'm the only one. So drug safe and efficacious, these are exactly the criteria that were in the inclusion and exclusion criteria. So it fits exactly with what we're talking about. So I would hope that everybody in this room would say, safe and efficacious drug, I'm not worried about the cost. These are the patients that got studied in the trial that we probably should treat unless there's something that I'm not telling you, and I actually can't answer that. All right, so if you give the same patient asthma, would you use this drug? Who would use this drug to treat a patient with asthma? Okay, so that's the negative control. All right? So we got a positive control, we got a negative control. What if we do this? What if we say this patient has a known genetic abnormality that's associated with the development of lung fibrosis and fits all the other criteria associated with who is in the trial. Who treats this patient with that drug? All right? So we'd say, yeah, basically everybody. Okay, what about this patient? Same story. Age is outside the range of what we studied, and the physiology is a little bit lower. So who's going to treat this patient with that drug? All right, so what we've just proved is that we're not going to limit ourselves to the actual phenotype of the patients that we studied in the trial. So we're willing to say that outside of that phenotype, there are probably some patients who might benefit from this drug, right? That's fair. We do it all the time. What about this patient? Fits all the criteria except he doesn't have IPF, he has asbestosis. Who's going to treat this patient with this drug? So some people are not. That's very interesting. What are you going to treat him with? We don't have time for that. What about the same patient with rheumatoid arthritis, with progressive fibrosing lung disease? Who's going to treat this patient with that drug? So a few more. There's something different about RA and asbestos, apparently, that allows you to feel more comfortable treating. What about this patient, progressive fibrosis associated with fibrotic hypersensitivity? Who's going to treat? So that's very interesting, actually. So what we can say is in those patients who fit the criteria of the drug that got studied, almost everybody treats. But then there's a whole bunch of us in here who would extend the indications for that drug, shown to be safe and efficacious in one type of fibrosing lung disease, to other patients with fibrosing lung disease. And so I just want to touch on some of these things and help us think about why we might or might not do that. So asbestosis has been around a long time. In the US, I can't remember the last time I saw an asbestosis patient. It's probably been at least a year. But if you're in Australia, and I can guarantee you if you're in the next 10 or 15 years in Russia and in China, you're going to see a lot of these patients. We know a lot about this. And the reason that I point this out is that there is something about exposures that occur very on that accumulates over time. Even if you get rid of the exposure subsequently, there's something that happens that continues to put you at risk for the development of fibrosis, particularly progressive fibrosis, and progressive fibrosis that will kill you, that is dependent upon the amount of exposure and the amount of time since the exposure. One could also make the argument that the amount of time since the exposure is also the body aging itself and maybe not exposure alone, that we don't understand. But we also know that this kills you, and while half the patients are going to die of progressive fibrosis, and some of that's dependent upon whether you're a smoker or not a smoker, or whether you were young or whether you were old when you did that, but there's also a significant increase in the development of lung cancer that we know occurs in fibrosis as well. So it might be somewhat unique in asbestosis, where probably a quarter of the patients will die of lung cancer, but still the majority of patients are going to die of lung fibrosis. All right, so one exposure, development of fibrosis. I certainly would treat that patient, given the absence of anything else, with a safe and efficacious drug. Let's go to the next thing, hypersensitivity pneumonitis. All right, so we know something about the mechanism, but we know very little about why patients develop fibrosis after they get hypersensitivity pneumonitis. We know that it can develop a whole bunch of things that occurs over time that is relatively independent of the duration of exposure. This patient actually had hypersensitivity pneumonitis on surgical lung biopsy, though I didn't do the surgical lung biopsy. And we've known for a number of years that if you look at the duration, once a patient has hypersensitivity pneumonitis, what happens over time is that lots of these patients develop emphysema, a lot more than similarly matched farmers without the disease. Some difference between smokers and non-smokers. Again, questioning whether a second hit might play some role there, but probably a doubling of fibrosis. Probably 10% of these, about 10% of these patients, as best we could calculate, died from progressive fibrosis in farmer's lung, something that we would otherwise consider should go away if you abated exposure, recognizing that in this cohort, 43% had continued exposure. And this is something we see all the time. You're a farmer, this is what you do. Generations before you have done that. If you have HP, this is the only job you can have. That despite that, the majority of patients will continue to do fine, but some subset, even if you get rid of exposure, will have progressive fibrosis. So Dr. Selman taught us this a very long time ago, that there are a lot of pigeons in Mexico City, and that some people can get chronic pigeon breeder's lung, and some patients, as best we can tell, have IPF with UIP on biopsy without significant exposures, but then there's a group of patients who have bird exposure and UIP on pathology. And their outcome, no matter how you addressed it, was exactly the same as patients with idiopathic pulmonary fibrosis. And Dr. Costabal and his group showed us something very similar, which is while there are different patterns seen on surgical lung biopsy in somebody with hypersensitivity pneumonitis, that if you get fibrosing forms of lung fibrosis in the patterns that we regularly describe, UIP and NSIP with a fibrotic component, that your outcome is significantly worse, even if you control for exposure and you treat. And then Jason Verlakis, before he went on to be a full-time critical care doctor, showed us this, which is if you took patients with hypersensitivity pneumonitis and looked at the surgical lung biopsy, and you looked at the biopsy and you said, if 5% of that biopsy is affected by fibrosis, I'm going to call it fibrotic. And you're going to basically have to have zero fibrosis in order to call this non-fibrotic, that there was a dramatic difference in outcome from patients who died of progressive fibrosing lung disease with respiratory failure, despite abating exposure and treating aggressively with immunosuppressive therapy, that their outcome was really not that much different than patients with idiopathic pulmonary fibrosis, and obviously quite different from those with a cellular interstitial pneumonia. You can do the same thing on CT scan. That all you have to do is find features that look like fibrosis with hypersensitivity pneumonitis, and your outcome is much worse. And it turns out, just like idiopathic pulmonary fibrosis, where we can measure the extent of disease, the extent of fibrosis, and that's closely associated with early mortality, that in an HP, if you measure the extent of fibrosis, you get exactly the same pattern. That the more fibrosis, the earlier your death, regardless of exposure, regardless of duration of exposure, regardless of treatment. It's also recognized in at least the Verlakis study that the duration of exposure was unrelated to the development of fibrosis. Oh, and the other thing is that just like IPF, patients with fibrotic forms of hypersensitivity pneumonitis get acute exacerbations and die with respiratory failure in exactly the same way. All right, what about connective tissue disease? So there's this big universe of connective tissue disease that we think about these days. There are these known characterized connective tissue disease disorders that are associated with respiratory signs, symptoms, and physiologic impairment. There's this giant group of patients who have a characterized autoimmune disorder who have radiographic abnormalities, and I'll come back to that. And then there's this group of patients who have some sort of ILD, frequently a fibrosing form of ILD, that have rheumatologic signs and symptoms but don't meet criteria for connective tissue disease. So you have these three big groups that actually we need to think about a little differently. So what if your patient has a defined connective tissue disease, signs and symptoms, physiologic impairment, what does it matter? So we know that since the biologic era in particular, that if you look at giant groups of patients with rheumatoid arthritis, that the overall mortality has started to decline, and it's actually declined quite a bit, 20% decrease in early mortality associated with rheumatoid arthritis in particular, a little more in men than in women, but men have a tendency to get worse disease and more destructive disease. But since the biologic era, things have gotten better. What has not gotten better is the development of fibrosing lung disease and resultant respiratory failure and death. That actually has gone up in the biologic era. So whatever treats the joints and a number of the other manifestations is not treating the interstitial lung disease. And if you do a fancy thing that suggests clinical significance by identifying interstitial lung disease or pulmonary fibrosis on a death certificate as an associated cause of death, we see the same increase, that more and more patients are being recognized as having significant clinically significant interstitial lung disease in the setting of rheumatoid arthritis. Now, some of this is case finding because CT scans are so readily available, but clearly this is a better recognized phenomenon than it was previously. So we also know that survival is short in patients with rheumatoid arthritis. Age-matched cohort, RA cohort here. If you have extra articular manifestations of the disease, it's this curve, which is likely responsible for all of this difference. So the big difference between RA, the early mortality of RA with a normal cohort, is probably all driven by these extra-articular manifestations. And we and the folks from Mayo a number of years ago did this study where we looked at patients with surgical lung biopsy that showed evidence of fibrosis on it and showed that that curve overlapped directly with those folks that had extra-articular manifestations. Oh, yeah, and these guys get acute exacerbations in exactly the same way that patients with idiopathic pulmonary fibrosis. Actually, this is the first study, as best we can identify from Park et al. In 2007, that identified patients who had something other than idiopathic pulmonary fibrosis that had exactly the same clinical phenomenon that occurred with acute declines, with respiratory failure, diffuse alveolar damage on the background of fibrosing lung disease that led frequently to early death. And Tristan Huey and Steve Frankel generated this study with consecutive patients that ended up in the intensive care unit with patients with interstitial lung disease and showed patients with idiopathic pulmonary fibrosis, but then a whole bunch of patients that had connective tissue disease with exactly the same clinical scenario. And while recognizing, that the outcome of patients with idiopathic pulmonary fibrosis and those with CTD were a little bit better, none of those patients with IPF survived a year. But it turned out 7 out of 10 patients with an underlying autoimmune disease died within that year as well. And the other thing that was really interesting is that regardless of what the underlying disease was and whether or not we could figure out why you had that respiratory failure, so if you had an infection, there you had hints of infection, you had some other explanation, so it didn't meet the strict criteria of an acute exacerbation, that the outcome actually didn't make any difference. So if you had an infection and it got treated, if you had a pulmonary embolus and it got treated, that your outcome was exactly the same. So there's something unique about the presence of lung fibrosis and acute respiratory failure that led to early mortality. My patient has diffuse lung disease and signs and symptoms without a defined connective tissue disease. Does this matter? Well, Dr. Corte and Dr. Wells came up with this scheme, which I actually love, which was really the question, addressed the primary question we want to know, which is if you have aches and pains and a positive rheumatoid factor but don't meet criteria for rheumatoid arthritis and have lung fibrosis, does it make any difference? And as best we can tell, the answer is no, that your outcome is exactly the same, and it's driven by the lung disease, and I at least would argue the progressive fibrosing lung disease that dictates your outcome, independent of what the clinical context or clinical scenario is. Okay, so you got a connective tissue disease, but you feel fine, but for some reason you get a CT scan of your chest. What should you do? So if you do CT scans on unselected patients with a variety of a variety of connective tissue diseases, it turns out that your CT scans are almost always abnormal. That it's actually quite rare to find a CT scan that is completely normal if you have an underlying connective tissue disease. But we already know that the majority of patients with connective tissue disease are not going to die of lung disease. So for some reason, the lung is involved, but in only a subset of patients is that disease going to progress to both clinical significance and maybe death. And so that gets us to Dr. Rosas' ideas about this subclinical interstitial lung disease. And he and Dr. Doyle did a lot of work that I thought I was going to have to do myself, but came up with this idea about the relative findings of abnormal radiographs under clinical significance thresholds in connective tissue disease, pulmonary fibrosis, and in smokers that suggest there's actually a fair bit of stuff that looks like what we would call interstitial lung disease, maybe pulmonary fibrosis, in a variety of clinical contexts that seem much more common in these clinical contexts than patients with recognized lung disease. And if you do biopsies on some of those patients for whatever reason, you find those fibrosing forms, those fibrosing patterns that we see, and we describe in other places, as part of that underlying pathologic response to something or another. So there's a whole bunch of people who develop interstitial lung disease and probably pulmonary fibrosis, but it seems like there's only a subset of patients who actually show progressive disease. So this is a nice scheme that they showed that suggested this is what this stuff looks like. And this was in a familial form of lung fibrosis in brothers who apparently were not particularly symptomatic, who both have fibrosing lung disease in a pattern that we would otherwise call UIP. Oh, and this subclinical interstitial lung disease that occurs in patients below the threshold of significance, they also get acute exacerbations with stuff that looks like this. A lot of this data comes from Japan, often taking out lung cancers with a little bit of interstitial lung disease with probably a 10%, somewhere between a 5 or 10% risk of acute exacerbation after after surgery. But here is where I get into trouble about this, because Dr. Wells, as he's shown us way in many places, he and his group came up with this idea. So all they did was ask the right question was, if you're older and you have a CT scan and you have no significant physiologic or symptomatic impairment, what does your CT scan look like? Well, it turns out that it's actually quite common in asymptomatic older folks to have radiographic abnormalities that are suggestive of fibrosing lung disease. All of these things, like reticular pattern, cysts, bronchial dilation, septal thickening, if you were on average aged about 80, these were actually quite common and rarely, if ever, seen in patients who were 40. Now we know it's going to be rare for those folks to die of lung fibrosis. So there's something quite separable about the development of some sort of lung fibrosis and the development of progressive fibrosis that dictates outcome. And the other interesting thing I found, I would have argued ahead of time that the answer to this question was, well, smoking probably accounts for all those radiographic abnormalities because we know smoking is related with some sort of dirty lung syndrome. And it turns out there was no relationship between smoking status or pack years and the development of those particular features that were suggestive of fibrosis. So if we had more time, I could make a separate argument about why UIP and NSIP really aren't that different, even though on CT scan they look different, and arguably on surgical lung biopsy they look a little different, recognizing that agreeability around these things turns out not to be very good, and there are findings of both UIP pattern and NSIP pattern and alternate patterns. But the key is here that if you have idiopathic pulmonary fibrosis characterized by a UIP lesion, that your outcome is poor. And while it's better with NSIP, for all of these patients, that's not that much better. All right, so what am I trying to say here? So pulmonary fibrosis is a problem. There is absolutely no question about that. Development is much more common than what we see, than what we recognize in clinical significance. But the real problem is progressive fibrosis. Not the simple development, but its progression. And those are the patients who develop symptoms, physiology, and die of respiratory failure. And progressive pulmonary fibrosis occurs in a variety of clinical contexts, but I would argue that it's the fibrosis and not the clinical context that dictates outcome. And I would also argue while it's perfectly reasonable to get finer and finer phenotypes that peel off other associated illnesses, that if lung fibrosis is actually the problem that we're struggling with, that think of the children, right? Don't create therapeutic orphans just because we now have created such a tight phenotype that only a handful of patients will fit its description. With that, I'll stop, and I'm happy to answer a couple of questions.
Thanks very much, Kevin. We have time for a few questions.
Perfect.
No, we do have a question in the back.
So Kevin, I think we've come a long way in understanding how to run the clinical trials in IPF, largely because of Intermune's activities. Are there any subsets of these interstitial lung diseases where you think we have a grasp of the disease progression, the number of patients that would have to be enrolled, how long we'd have to treat, so that we would be able to realistically run a clinical trial in one of these other interstitial lung diseases?
No. I mean, that's the short answer. You know, we've done a lot of trials over the years, and in a variety of ways have tried to enrich for a population of patients who were likely to progress during the course of that trial. And to the best of my knowledge, there are many people here who are much smarter than I am about this, but I would argue that we have been singularly unsuccessful at identifying unique clinical criteria that would regularly predict much faster progression than the routine take-all-comers population that I would argue is just as reasonable and just as likely to give you a hit if you've got a good drug.
And then the other question I have relates to one of the big questions is if we develop a very good antifibrotic, whether or not at the end of the day that's going to be likely to have clinical benefit. So do you think, in terms of understanding the progression of disease in these patients, that there's any particular subset that you're absolutely convinced that if you develop a good antifibrotic, it's going to translate into a clinical benefit?
Yeah, I mean, this is one of those things where what I think is probably irrelevant. I think if you, despite what we all sort of in my alternative universe, what we voted on, my strong suspicion, I actually would be willing to bet a lot of money on it. If you showed an efficacious antifibrotic drug in one narrow subpopulation that basically everybody with lung fibrosis who had clinically significant and progressive disease at least would be tried on it. And I say that simply because of historical precedent, which is we treated patients with a whole variety of forms of lung fibrosis with the same therapy for many years. Recognizing that we didn't really understand whether it was beneficial or even safe in some circumstances.
Professor Fabre?
Taking the message of your last slide, I think that you might benefit from identifying clinical phenotypes of pulmonary fibrosis. The one that has excess decline in lung function, the rapid decliner, the one with the exacerbation, the one with the comorbidities. And by doing that, you probably identify different diseases. That's one question. Then I have another one.
Yeah, so I absolutely agree with you. I think that would be wonderful if we could predict the future and what was going to happen with each patient. But to the best of my knowledge, at least to date, we are unable to predict, based on any available clinical data, who is likely to progress.
Yeah, the first day we had a presentation of the GSK-sponsored study that is very similar to a study done in COPD where patients were followed, the Eclipse study, were followed for 3 years and provided quite a significant amount of information in that population that we now benefit. The second question to you is the following. I'm not in this field, but I noticed that you focus most of your attention on CT scan or comorbidity or other stuff, and you don't, or at least I did not perceive that you pay enough attention to the symptoms. We figured out in a different disease that including symptoms and exacerbation, we actually identify a subgroups that we thought there was a low risk. That is the highly symptomatic but low risk, meaning that they don't have exacerbation, they don't have impaired lung function, but they do have a lot of more comorbidities, they die earlier, they have so I think that you should consider in assessment of severity to include the symptoms by using simple scale, like the MRC modified and the number of exacerbations, this kind of stuff.
I agree. Actually, Kevin Flaherty, I think, was one of the first to point out that in many of our studies, prior to decline, symptomatic scores started to decline and were predictive of what was going to happen physiologically going forward. And in our own data, Hal Collard actually showed us this, which was that worsening symptom scores were at least as predictive and maybe more predictive of early death than changes in physiology.
Kevin, Jerry Cox from McMaster. The work that you've done, and in fact you said it very early on, that radiology predicts what's going to happen, has been very, very helpful to many clinicians. But one thing we've found, a few people who don't have any fibrosis on their CT scan and yet have a dismal disease course. So I wonder if you have any thoughts that what else should we be looking for? What would be another parameter that we might identify that would help us, because there are, for these people who don't have much fibrosis but have a relentless progressive course.
Yeah, I think that's important. It's very clear that at least half the patients have a CT scan pattern other than the UIP, typical UIP that we would all start to be worried about, but have exactly the same relentless course and are just as likely to have acute exacerbations. In those patients, I think in particular, symptoms and physiology are better predictors of what's going to happen than just the baseline CT scan pattern. And actually the serial CT scan pattern, at least anecdotally in our hands, that changes in CT scan over time and typical UIP patterns are actually quite predictive of a progressive course. When you have an atypical pattern, it's not as predictive. So worsening symptoms, worsening gas exchange, and worsening physiology are as strongly predictive in that group as they are in the typical group.
Just a comment, Kevin, I really enjoyed your talk, and I think it would support a hypothesis where we think these diseases start, and it's beautiful evidence for gene by environment interaction, but that there's maybe a biology that becomes autonomous of environmental cues. And in a sense, we have some hypotheses that matrix stiffness or epigenetic modification may allow the disease at some point to become self-propagating or self-sustaining independent of the environment, and that maybe that has a very similar biology however you get there.
I agree with you exactly. And the HP data would suggest that. In some ways, the asbestosis data suggests that. There's a question of whether there's a threshold effect, i.e. like in the RA patients who all have radiographic abnormalities and only some progress. So is there enough fibrosis? Is there some combination of change with age and threshold? But I agree with you exactly. There's a trigger. Where there's a second trigger, I can't predict. But it's clear that something happens that sets off progression that's independent of the original cause.